Bueno, buenas noches, buenas tardes, en un horario diferente en el día de hoy, debido al tema y a la jerarquía de nuestro invitado. Vamos a abordar un tema y tenemos un invitado que es de Europa, con lo cual hemos cambiado el horario. Vamos a dar comienzo entonces a nuestro tercer seminario web de la comisión del Comité de Cirugía Mininvasiva de la Asociación Argentina de Cirugía. En este caso le corresponde su organización a la subcomisión de cirugía colorectal y coloproctología a cargo del doctor Ricardo Mentz, así que le doy la palabra al doctor Mentz para que presente a nuestro invitado y el tema y a los comentadores. Ricardo.
Bueno, buenas tardes. Muchas gracias, Fabio, por la introducción. La verdad que es un gusto estar hoy acá en este seminario que tiene como tema principal una de las estrategias que utilizamos para mejorar la calidad de atención que le damos a nuestros pacientes en nuestra actividad principal, que es la cirugía y todo el acto perioperatorio. Quiero agradecer a la autoridad de la Asociación Argentina de Cirugía que nos ha brindado este espacio y los recursos para poder llevar a cabo esta actividad, que en esta oportunidad va a ser abordaje mininvasivo y ERAS en cirugía colorectal, y la conferencia de exposición va a estar a cargo del profesor Tim Rockall, que es cirujano colorectal consultor en Guildford, del Reino Unido. El doctor Rockall es autor de innumerables trabajos que han sido publicados y citados varios miles de veces en referencia a cirugía colorectal, cuidados posoperatorios, analgesia intraoperatoria, fisiopatología y por supuesto sobre ERAS, ¿no? Es uno de los autores de las guías de la Sociedad Internacional de ERAS publicadas hace un par de años, y es uno de los autores principales del primer trabajo sobre colectomías laparoscópicas con menos de 24 horas de internación, que se publicó hace ya un poco más de 10 años. No quiero gastar más tiempo hablando del doctor Rockall, va a ser más importante escucharlo seguramente, aunque todavía debo presentar a otros 3 panelistas. 2 de ellos son cirujanos, que tienen especial interés en la cirugía mínimamente invasiva y en ERAS, prácticamente desde que este movimiento se ha iniciado en nuestro país. Uno es el doctor Fabio Leiro, que acaba de hablar, que es el presidente de la Comisión de Cirugía Mininvasiva de la Asociación, y cirujano coloproctólogo del Hospital Pena y de la Fundación Favaloro. Y el otro es el doctor Juan Patrón Uriburu, que es cirujano coloproctólogo del Hospital Británico de Buenos Aires. Por supuesto, no podía faltar en ERAS un invitado transdisciplinario, que en este caso es un anestesiólogo, es el doctor Adrián Alvarez, que es anestesiólogo del Hospital Italiano de Buenos Aires, con el que tengo el gusto de trabajar prácticamente todos los días. Es el presidente de ERAS Latinoamérica y es el gran motor e impulsor de ERAS en Latinoamérica y principalmente en Argentina. Dicho esto, quiero invitar al doctor Rockall a que nos brinde su exposición sobre abordajes mininvasivos y ERAS en cirugía colorectal. Adelante, doctor.
You will be aware that in many specialties and in many countries, minimally invasive surgery is now the standard of care, certainly in colorectal disease. In my own hospital, for elective colorectal surgery, 95% of all cases are done laparoscopically and have been for the last 15 years or so. But around the world, it is also happening, and the numbers are increasing at the expense of open surgery. During the same time frame that has happened, that minimally invasive surgery has developed, there's been a widespread acceptance of enhanced recovery after surgery principles. Why is this important? Well, the fact is that minimally invasive surgery helps enable many of the standard enhanced recovery interventions. You'll see on this slide that many of the interventions that are important in enhanced recovery are actually made easier if you're able to do it within minimally invasive surgery practice. Now, ERAS has evolved quite quickly over the last 25 years. The term fast track surgery was first used in 1994, in fact, for cardiac surgery, and was first mentioned in colorectal surgery in 1995. It was in 1999 that we first had Henrik Kellett's important publication of demonstrating how you could enhance the recovery of open sigmoid resections to the extent that they could be discharged within 2 days, something unheard of at the time. But the term fast track has really diminished and with the development of the ERAS study group and subsequently the ERAS Society, the emphasis has changed such that the emphasis is on the quality of recovery rather than the speed of recovery, as well as an emphasis on the resolution of issues that delay recovery and cause complications. And so the important thing that has happened really is a recognition that perioperative care is as important as the operation itself in determining the outcome. So how does enhanced recovery influence outcome? Well, it does this by impacting upon the pathophysiology of surgical trauma. All surgical trauma leads to a stress response, which has metabolic effects. And whilst this is an evolutionary metabolic response to injury to conserve fluid and mobilize substrate, we know that through a complex cascade of events, that these are potentially harmful in the context of elective or emergency surgery in hospital care. I think one of the best definitions of enhanced recovery is that it is essentially a multidisciplinary attempt to moderate the stress response and improve outcome. So the impact of ERAS, I don't think you should think of as really being about length of hospital stay. The length of hospital stay is merely a surrogate marker of the improved outcome that you see when you undertake enhanced recovery. And it does this by reducing complications, reducing intensive care utilization, improving mortality, and potentially improving cancer outcomes as well. We know from the work of Curie and indeed others that complications have a major impact on long-term survival. In fact, it turns out that the single most important predictor of long-term survival is not preoperative risk, but whether there was a major complication within 30 days. So if your enhanced recovery reduces complications, then ultimately you can expect it to improve mortality too. There have been a number of meta-analyses and of small studies comparing colorectal surgery within both enhanced recovery and standard protocols. And the meta-analysis would suggest that you can reduce complications overall by 40 to 50%. Along with this comes a reduction in hospital stay, which benefits the patient, it benefits the hospital, it benefits the economy. And in 2003, when I first moved to Guildford, the average hospital stay for elective colorectal surgery was 12 to 14 days. This was predominantly with open surgery. Within a few years, the average hospital stay had come down to 2.5 days. And as was alluded to earlier, we now discharge 25% of our elective colorectal resections the day after surgery, so within 24 hours of their operation. And that is something that is achieved in many hospitals now. It's not just about hospital stay, it's also about a better patient experience. This patient is one of our patients going home the morning after their left hemicolectomy. And we've done some research looking at EQ5D scores and SF36 scores, which very convincingly shows that the quality of life of these patients is enhanced both by a laparoscopic and an enhanced recovery process. There is some evidence that it also leads to improved survival and improved cancer survival. This is our contribution to that data, but there have been many studies which are tending to show an improved cancer outcome for patients. So 25 years on since ERAS really came to the fore, and I think around the world, many of the principles of ERAS are broadly accepted, but it has to be said that it is very variably delivered. And we know that outcomes vary hugely around the world in terms of mortality for the same surgical operation, also variation in length of stay between units within the same country, and adjusted reoperation rates, for example. The question is, this variation in outcome, what is it due to? Now, some of it will, of course, be the quality of surgery that we deliver. That does have an impact. But I truly believe that much of it is actually due to variation in the quality of the perioperative care that is delivered. It is very little to do with case mix variation. And it turns out, if you read the literature, that good outcomes seem to have very little to do with patient selection. It's much more to do with how you manage those patients. So what then is this big challenge of ERAS? Why is it so variably delivered? Why do some people do it brilliantly, some people do it cursorily, and some people not at all? Well, the truth is that we have to impact care at multiple points during a patient's journey, all the way from their presentation to the general practice, through their pre-assessment, anesthesia, surgery, onto the ward, and on their way home. And each of these different areas has its own focus, it has its own personnel, and has its own specialists. And that is a challenge. So in this slide, which shows all the different time zones during a journey where you can impact upon a patient's recovery, there are many, many different people involved. So all those elements have scientific support, but they're delivered by different people in different departments in different physical spaces. And the only constant factor is actually the patient. And I think our role as a surgeon is to have an overview of the whole treatment of the patient. And we do that by implementing a multidisciplinary team approach towards enhanced recovery. And this is very important because of the 19, 20, 21 elements of a standard ERAS protocol, no single element improves outcome dramatically on its own, with the exception of minimally invasive surgery. But of all the others, as they are not independently improving outcome. It's important that you deliver the whole spectrum of the protocol. Now, I have a slightly simplistic view of the elements of a standard ERAS protocol, because it can be a bit daunting to have 20 of them to attend to. And I regard them as either negative or positive elements. And I think we can avoid harmful negative interventions that are potentially detrimental to the patient. And then there are the positive interventions that actually improve recovery. So negative interventions, for example, are mostly the dogma that we are trying to reject in terms of post-operative care. So simple things like the overuse of nasogastric tubes, prolonged use of urinary catheters, prolonged use of abdominal drains, prolonged starvation, unnecessary bowel preparation, undue immobilization. These are all negative things that need to be rejected and stopped. And in many respects, it makes management easier, not more difficult. And why do I call them negative? I call them negative because at best, they do not work. They tend to slow recovery. They tie the patient to the bed. They're unpleasant for the patient. They cost money. And at worst, they can cause harm through increasing complications. And then there are the positive interventions that we do within an ERAS protocol. And these are much less about those dogmas that I referred to, and much more about education in terms of the pathophysiology of surgical trauma. And the crucial positive interventions are all about two things, in my opinion. And that is perioperative fluid management and perioperative multimodal pain management. And if you get those two things right, in conjunction with minimally invasive surgery, you'll go a long way to getting the optimal results. So what are the barriers to implementing a standard ERAS protocol? Well, there is always general resistance to change. That goes for anything in any sphere of life. Dogma we've referred to, it's sometimes difficult to combat. There are time constraints that we all have as surgeons and physicians. A lack of collaboration between the different team members and poor coordination. And often that is a result of poor leadership, the lack of local champions, sometimes exacerbated by poor interpersonal relationships, And certainly in the UK, consultants often are independent in nature when they should be more collaborative. And it's not just about starting a protocol and introducing a change. You've also got to maintain that. And there are barriers to maintaining a change in practice. So protocols, ERAS protocols only work if you are compliant with them. And there is a natural tendency for compliance to reduce over time, partly because of a lack of ongoing education, a lack of audit, and the obvious change in personnel that occurs on a regular basis on the wards and in the hospital. And if you're going to maintain a protocol, you need a multidisciplinary team, both for communication and collaboration. You need your hospital management to buy into the process, and you've got to work towards standardization and normalization, such that your ERAS protocol becomes normal. You don't even need to talk about it as being an ERAS protocol, it just becomes normal care. And the key to maintenance is audit. You will only know if you're achieving what you want to achieve by auditing what you do. So the key to successful ERAS, I believe, is a team, a leadership of that team, ongoing audit, boosted by research, and the whole team has to have an openness towards continual change. It represents a philosophical change in attitude of the whole extended team. So first of all, you need leaders, and leaders of change in surgery are usually the surgeon, but it doesn't have to be. It could be anybody in that team. The day-to-day management of an ERAS protocol is often a nurse, but again, it doesn't have to be. But what those managers need to have is time. Time to attend to the practical matters of introducing a protocol and making sure that there is compliance, time for coordination, time to train all the new personnel that come into the process, and time to corral and coordinate specific disciplines. Team meetings are critical, and audit is fundamental. Leadership, I think, is best done by example, by initiation and demonstration, but the leaders also have other roles. They have to be the ones who are in the hospital resisting the skepticism, which inevitably is there from the beginning because there's change, maintaining the program, giving responsibility to other team members, and also sharing the rewards of success. And ultimately, to get a high-performing surgical team, you need a team that is focused on results. And this is a publication that is free to access from the Royal College of Surgeons of England on how to develop a high-performing surgical team, which I commend to you. Let's take the example of a colorectal team and a colorectal protocol. There's all sorts of people who could be involved in a patient's journey through the hospital. And the critical members of that team really depend on the speciality. So for a colorectal team, it's going to be very important that the surgeon, the anaesthetist, the nurse specialists, the ward nurses, the junior doctors, and for colorectal disease, the stoma care team are really involved in every patient's management and every patient's enhanced recovery process. Of course, there's the patient, and you need hospital managers. But now, if I was talking about esophagogastric resection, for example, this list would look slightly different. There would be much more emphasis on the intensivists and the dietitians and the physiotherapists. But for colorectal disease, there are really the absolute essentials that you need to have on board for your ERAS protocol. And that is the anaesthetist. This is a picture of Mike Scott, who was my anaesthetist in Guildford for many years and is now an intensivist in the USA. There's myself, the ward-based team, and the specialist nurses. And if you've got those driving an enhanced recovery protocol, you will achieve almost everything you need to achieve. So if you want to start simple, start with the absolute essentials. How do you maintain compliance and do audit? Well, ensuring compliance needs motivation, and you need audit to ensure that you are compliant. Now, compliance can be compelled, but it's not always successful when you do, and it can be encouraged. At the bottom of the screen here, you see something called sequin payments, and this was something that was done by the Department of Health in the UK to try and improve compliance with enhanced recovery. And what happened was that if you could demonstrate that you as a hospital did a number of things, then the hospital received increased payments for each episode of care. But of course, it's much better if these things are all done willingly. Audit is important because outcomes are rarely what you think they are. And that's even if you are intrinsically honest. You don't really know what your outcomes are until you measure them. And we also know from the work of Gustafsson and others that the best outcomes from the ERAS protocol come with the highest compliance. You've got to be compliant 70 to 80% to get those best results. The greater the compliance, the better the outcome. And there are many different audit systems that you could use. This is one that the ERAS Society produces, the ERAS Interactive Audit System, but it doesn't really matter whether you use this or some other audit system. The important thing is that you measure what you do. And I have to say this is particularly important when you first start off introducing a new program. Once you got to a stage where this becomes normal practice, then it is not so important, but it's absolutely critical at the beginning that you can demonstrate that you are doing what you think you're doing. And an audit system is the best thing for that. I think as leaders of ERAS in your hospital, you probably also need to be innovators. Because when faced with a protocol, some of those elements of a protocol don't necessarily fit in with your individual hospital. And the other problem with protocols is they can become dogmas in themselves, and things move on, evidence changes, new things happen, and I'll give you an example in a moment. And so I think research is important. And these just represent some of the areas that we have researched during our development of ERAS in our hospital since about 2003. We looked in great detail at the various laparoscopic approaches to surgery. We've looked at intraoperative fluid management, looking at the best fluid protocols and how best to use them with the esophageal Doppler. We've looked at low pressure laparoscopy, and we've looked at the optimal analgesia protocols, including randomized controlled trials in many of these areas. Ultimately, I think what we're trying to achieve is what I would refer as normalization. And I think ultimately you have to get to a situation where what is euphemistically called standard care actually becomes unacceptable care. So ERAS is the normal. And this has to be the ultimate goal of any ERAS implementation plan. I said earlier that abandoning dogma is important in enhanced recovery, and I do think it's one of the cornerstones of ERAS. The challenge of dogma, I think for us as surgeons, is that every new conclusion coming out of research or other evidence that rejects a dogma has the potential to become a new dogma. And then you have inherent resistance to challenging that new position. So it's perfectly acceptable, I think, to constantly challenge the facts if necessary and change your protocols accordingly. The ERAS guidelines are updated every few years for good reason, because new evidence comes along and things change. The guidelines are only guidelines. They are evidence-based, but often the evidence is limited, which is one of their criticisms. And many of the strong recommendations actually have quite weak evidence behind them. And so challenging those position statements, I think, is always valid, but it has to be done with robust research methodology. So this is an example. So back in 1999, when Henrik Kellett published his open sigmoid colectomy data, one of the absolute pillars of the protocol was the use of thoracic epidurals. It was a real cornerstone of the fast track approach. And subsequent to that, the use of thoracic epidurals in colorectal resectional surgery became very widespread, or it certainly did in Europe. It almost became the standard of care. But shortly afterwards, certainly we started, and many institutions around the world started doing more and more laparoscopic surgery to the extent that it actually became normal. But despite this, the anaesthetists continued to use thoracic epidurals. Now, we did a study, an observational study, which very clearly demonstrated to us that the patients who received thoracic epidurals actually stayed in hospital longer than patients who didn't. So we subjected this to a randomized controlled trial of epidural versus spinal versus patient-controlled analgesia, and that absolutely confirmed that the thoracic epidural group for laparoscopic surgery had a worse outcome than those having a spinal or a PCA. The end result of that is that the newer guidelines of perioperative care and colorectal surgery do not recommend thoracic epidurals for colorectal cancer surgery if it's done in a minimally invasive fashion. So this is just an example how you can challenge the elements of guidelines through research. So to conclude, the evolution of minimally invasive surgery has occurred simultaneously with that of ERAS, possibly by coincidence. In many countries, minimally invasive approaches are now the standard of care, and I don't know whether that is the case in Argentina, but I suspect it may well be. The minimally invasive approach is one of the few independently significant factors in improving outcome. Of all the elements of an ERAS protocol, it is absolutely critical in my view. And there's no doubt that the best outcomes are achieved by excelling in both the surgical technique and the optimization of perioperative care. But that is not to say that ERAS does not have benefits for patients undergoing open surgery. It has profound benefits for those patients, but of course you will not get the same results than if you use minimally invasive surgery. So this is my last slide, and just really demonstrate what I regard as the three absolute pillars of optimal colorectal perioperative care. And the middle pillar is the delivery of good quality minimally invasive surgery, supported by optimized fluid management and good non-opiate multimodal analgesia. And if you can achieve just those three things, you will go a long way to a successful program. Thank you very much.
Muchas gracias, doctor Rockall. Muy amplio y muy preciso los conceptos que nos ha brindado. Quisiera invitarlo al doctor Juan Carlos Patrón Uriburu a que nos brinde algunos comentarios sobre la exposición, por favor.
Bueno, buenas tardes, gracias por la invitación a participar de este módulo tan interesante. A mí todos estos protocolos ERAS me interesan hace mucho tiempo y estamos en nuestro hospital y en el país intentando aplicarlos, pero bueno, no es tan fácil en un medio como el nuestro, en donde los progresos se hacen en forma más particulares o más independientes que con soportes estatales, ¿no? Yo conozco un poco más el programa LABCO en Inglaterra, pero me imagino que MATU debe ser similar, que tienen cierto sponsoreo estatal y quizás todos estos protocolos sean más fácilmente aplicados en el Reino Unido que en Argentina, ¿no? Porque vienen de impulsos estatales y a nosotros, bueno, tenemos que ir empujando quizás cada hospital por su cuenta. Quería felicitarlo al doctor Rockall por los conceptos que nos ha dejado, y para mí hay dos conceptos que fueron realmente reveladores, ¿no? Entre todas la conferencia, que ha sido muy valiosa, y uno de esos conceptos es que ya Inglaterra ha llegado al 95% de adopción en cirugía laparoscópica, y esto es gracias justamente a estos dos programas que yo les comenté seguramente, al LAPCO y MATU. Y por otro lado, que ya han dejado de usar o de recomendar la analgesia torácica epidural. Esto es algo que todos los que estábamos involucrados en los protocolos ERAS defendíamos con mucha energía, ¿no? Y la última recomendación ya parece no recomendarlo más. Y de esto se desprende la primera pregunta. Quisiera saber ¿qué otro elemento ustedes consideran que se puede llegar a cambiar con la incorporación de un 95% de procedimientos laparoscópicos en el Reino Unido? Ya modificaron esto, ya modificaron el tema de la analgesia. ¿Qué otro componente más están viendo que se pueda a llegar a modificar por la laparoscopía?
Thank you for the question, and thank you. As I said at the end, I think that the analgesia protocol is really crucial, and our analgesia protocol, we have abandoned the thoracic epidurals, but we still use regional analgesia. So we use a spinal injection, a one-shot spinal injection at the beginning of the operation as an alternative to an epidural. There are far fewer complications and much easier fluid management issues afterwards. But definitely abandonment of the thoracic epidural is the right way to go. We also avoid all opiate analgesia, if possible. I regard the opiates as a bit of a poison for our colorectal patients, and I'm sure you recognize it. It causes nausea, it causes constipation, it causes ileus. The patients don't really like it. The only thing they are quite good at is controlling acute pain. But there are other methods. So we use a regular paracetamol together with a regular non-steroidal, and that is for every patient. And then we use some synthetic. We do have opiates written up for breakthrough pain, but through a process of talking to the patients beforehand and after the surgery, telling them how important it is to try and avoid opiates if they can. Most patients actually do avoid it quite well. It's not something that's easy to do in open surgery, but in laparoscopic surgery, total opiate avoidance is possible. Not in every patient. You're not going to achieve this in everybody, but if you can achieve it in the majority, you'll go a long way. We very rarely see significant ileus in patients anymore. And that's partly because of the laparoscopy, partly because of the avoidance of opiates, and then partly because of the fluid management. So that's the other thing I would come to. I think the fluid management is absolutely critical. And fluid management, one of the problems with the epidural was that post-operatively, it made fluid management very difficult, because with a thoracic epidural, it's very common for the patients to be hypotensive on the ward, and that was usually combated on the ward by giving the patients fluid. And you'd be surprised how much fluid, maybe you wouldn't be surprised, but a lot of patients were given huge volumes of normal saline to maintain their blood pressure. It is absolutely devastating for those patients' recovery. Too much salt, too much water. So we intraoperatively, we use an esophageal Doppler to measure their cardiac output so that we know whether they're fluid depleted or not. And if they become hypotensive during the operation, it's not usually because they're hypovolemic. And actually what they need is a vasopressor, not fluid. So in an average elective colorectal resection, our patients might receive 1 liter of fluid during the operation, 1 liter. Okay. Yeah. At the end of the operation, that's it. Okay. They get to drink. They can have a cup of tea. They can have a drink. Some patients, you may need to give a bit of fluid, but certainly by the following morning, no intravenous fluids, none. Okay, and that's if you follow standard anesthetic and surgical protocols, it's not uncommon for patients to be 7, 8, 9, 10 liters positive, and to weigh 7 or 8 kilograms more 2 days after the operation than they did before the operation. It makes the patients feel ghastly. So you need to, I think, get together with your friendly anaesthetists and work out a fluid protocol that works best for the patient. That, I think those 3 things are the critical things.
Excellent. Thank you very much.
Pleasure.
Sí, tengo varias preguntas, ¿no? Pero voy a hacer una más solamente para dejar al resto. ¿Cómo ven ustedes la incorporación de los protocolos, las prehabilitaciones? Protocolos de prehabilitación. ¿Van a tener el mismo empuje que un protocolo ERAS o piensan que no va a tener tantos adeptos? The rehabilitation programs.
Okay, I understand prehabilitation. I think prehabilitation is a much more difficult area. I think we all believe that if you're fitter at the time of surgery, you will do better. Everybody believes that, because whenever we see a patient who's unfit, we think, oh my God, he's going to do terribly. He's so unfit. We all know that if you're fitter for surgery, you will do better. The question is, how do you get someone fit for surgery? And it is undoubtedly the case, and we've done several trials and studies on it. You can get patients fitter for surgery, measurably so, in terms of their oxygen delivery, for example, and their heart function, within just a few weeks with exercise programs and things like that. But it's something that you can do within a research protocol relatively easily, because you've got research fellows driving it and staff financed to do it and motivated patients. It's much more difficult, I think, to introduce into a general hospital process. And it is particularly difficult to do for the cancer patients, because I don't know what it's like for you, but in the UK, we have very strict time targets in which we have to diagnose and treat our cancer patients. They basically have a 30-day pathway. So from diagnosis to treatment. And so to introduce a prehabilitation program into that is extremely difficult. It's also very labor intensive. You know, an exercise program, supervised exercise program, is very labor intensive. I think if you can do it, it's great. But it is definitely the case that it is difficult to implement. So all the research suggests it's probably beneficial, but also the research suggests it's very difficult to actually do. But I think I think there may be a change. I think there's a big opportunity for modern technology here, for apps and websites and that sort of thing to motivate the patients to do exercise, for things, Fitbits that monitor how much exercise you do. But it remains to be seen. But it's definitely considered. I think we probably need to do prehabilitation, not necessarily for everybody, but for a selected cohort of patients who we know will do much better with their surgery if they are fitter. And it's worth delaying their surgery if you can, in order to achieve that. But you need to have, you know, dietitians and physiotherapists and all sorts of things delivering that care, because most patients will not be motivated to do it themselves.
Gracias.
Bueno, muchas gracias, Juan Carlos, por tu participación. Creo que nosotros tenemos los mismos problemas con la prehabilitación, los tiempos y la motivación que tienen los pacientes, ¿no? Es una limitante importante, digamos, para poder lograr buenos efectos en esa área. Fabio, te invito, si querés hacer algún comentario, por favor.
Bueno, muchas gracias, Ricardo. se me escucha bien, ¿no? Muchas gracias, doctor Rockall, por la brillante conferencia, que realmente ha tocado muchos de los puntos que a los que hemos estado interesados en esto nos hemos chocado, ¿no? Está claro que digamos, la práctica de ERAS es una práctica que no debería tener, digamos, tan poca aceptación. Se sabe que los hombres respondemos a incentivos y creo que en este caso están todos los incentivos alineados porque, digamos, son todas cosas a favor. Los pacientes se recuperan más rápido, tienen menos complicaciones, se reducen los costos, hay menos dolor. Creo que nadie podría estar en contra de esto. Sin embargo, por alguna razón no se impone digamos, o no se ha difundido como todos deberíamos pensar que debería ser. El doctor Roca se refirió a 3 pilares, 3 intervenciones que son pilares, que son el manejo del dolor, el manejo de los fluidos, la cirugía mininvasiva, y por eso será quizás que los anestesiólogos y los cirujanos somos los que más impulsamos esto, y somos actores principales para desarrollar un programa de ERAS, pero hay otros actores que también son pilares, que son los managers de las instituciones, los pacientes y la enfermería. Y ahí es donde tenemos problemas en nuestro país, yo creo fundamentalmente, porque los managers tienen mentalidad de corto plazo, no tienen mentalidad de largo plazo, los pacientes tienen una idiosincrasia y además cuestiones sociales, sobre todo nosotros que nos manejamos en un hospital público, donde es difícil implementar esto, porque o viven lejos del hospital, o no, o es difícil que entiendan o interpreten bien las indicaciones que uno les da. Y además la enfermería, lamentablemente, lo voy a decir, es una profesión que todavía tiene poca jerarquía en nuestro medio, y eso también creo que es algo que atenta contra la implementación. Creo que también hay un tema que es el manejo del dolor posoperatorio. Todo el tiempo nos chocamos contra una tradición en todos los médicos que comparten muchas veces el manejo con nosotros, tanto dentro de terapia como fuera de la terapia, donde hay una gran propensión a indicar opioides y tenemos que pelearnos todo el tiempo con este tema. Y creo que bueno, en definitiva es difícil implementar ERAS, un poco por lo que decía el doctor Rockall, que es que los resultados no son los ideales si no hay un buen cumplimiento. Cuando uno desarrolla un programa de ERAS y no lo desarrolla de principio a fin, y donde no hay un buen cumplimiento, los resultados no son tan buenos, y eso hace que se retroalimente una cuestión de no llevarlo adelante o no sostenerlo en el tiempo, como él nos explicaba. Y el otro tema es que se requiere mucho manejo, mucha interdisciplina, ¿no? Mucho diálogo, y ese también es un tema que a veces resulta difícil en nuestro medio. Nuevamente le agradezco, realmente creo que es una conferencia, una charla muy motivadora, que todos los que escuchamos nos abre mucho la cabeza y nos hace pensar mucho y plantearnos cómo hacer para intentar llevar adelante un programa de esto. Yo quisiera hacerle una pregunta. Nosotros hemos intentado también los programas de rehabilitación y ha sido complicado, pero puntualmente mi pregunta tenía que ver con el tema de la analgesia posoperatoria y el abandono de los bloqueos epidurales torácicos. Nosotros hemos utilizado el bloqueo TAP como medio de analgesia. Quería saber si le ve algún lugar, si tiene alguna indicación y si cree que puede tener alguna utilidad. Esa sería mi pregunta. Muchas gracias.
Yes, I did. So tap blocks have been shown to be a good adjunct as part of the multi-modal analgesia. We don't use them, partly because we've had such good success with using a spinal injection instead. But there's a lot of people in the UK also use tap blocks, and there are other methods as well. Anything that reduces your reliance on opiates is good, and not everybody has to have the identical identical protocol. It's what works best in your hospital, and if you are, or you're an anesthetist, or you are good at putting in tap blocks and are prepared to put the time in to do it, then fantastic. That's probably as effective as a spinal. We've just got quite slick at doing the spinals. The anaesthetists are all very good at it. It's very quick, it's very easy, and it's very reliable. I think the tap block requires a degree of expertise to make sure it's done properly, but it's a good method. Yeah, absolutely. I think one of the issues you alluded to was that it's, you know, it can be a bit daunting, the complexity and the multitude of different things that you need to do within an ERAS protocol. And I think if you're struggling to introduce it, I think you've just got to really concentrate on the crucial elements, which is what I've tried to bring over in my talk. And perhaps you don't need to do them all at once, but you do need to bring people with you, that's for sure. But perhaps, you know, introducing the whole thing in one big go is not the right way. But if you can get your surgical colleagues, the nursing colleagues, and the anaesthetists to all agree an analgesia protocol for these patients, then you just need some form of leadership to make sure it happens. And these things do work. So ultimately, people will see that they work. And I think, and it is a shame if the hospital management are not behind these things. It's the same in the UK, don't get me wrong. You know, we have a huge variation in the UK. Some hospitals don't really do it very well at all, or at all, either the minimally invasive surgery or the enhanced recovery. We're not all good at it. But there are huge advantages to the hospital to doing it. And the reality, there's huge advantages to the whole hospital system, because doing most of the elements of a successful enhanced recovery process are all about doing less and making post-operative care more simple, less nursing intensive. It's about making it easier. In fact, we are doing less to the patient. We're relying much more on the patient's natural ability to recover from operations. That, you know, we're relying on their homeostatic mechanisms. So instead of giving them intravenous fluid, we're letting them drink. Instead of giving them opiates, we're doing minimally invasive surgery so it doesn't hurt so much. You know, it's all simple things. We're not putting nasogastric tubes in, so you don't need to monitor that. We're not putting drains in, you don't need to monitor that. We take the catheter out the morning after the surgery, so you don't measure the urine output. We don't do any blood tests if the patients are well. It's all about doing less. It's not doing more. So everybody should be happier, but it's difficult to convince people sometimes. The best enhanced recovery, you know, operation that we do is we virtually do nothing to the patient. They have a really good anesthetic, a really good operation, and then shortly afterwards we take everything out and just let them go, let them eat and drink. And they are the patients who do the best.
Muchas gracias. Totalmente de acuerdo. Muchas gracias. Estás apagado, Ricardo.
Perdón. Muchas gracias, Fabio. Juan Carlos, ¿levantaste la mano para hablar?
Sí, quería ver si podía hacer una pregunta más.
Sí, adelante.
Hay algo que se le criticó en algunos trabajos a los protocolos ERAS, y es la rigidez de los protocolos ERAS. O sea, que el mismo protocolo se debe ajustar a todos los pacientes, y no todos los pacientes son iguales. Un poco se habló ahora de cierta flexibilización de ciertos protocolos dependiendo de los países, el medio ambiente en el que uno se desenvuelve, y quizás podríamos sumar también la complejidad quirúrgica o la complejidad del paciente. ¿Usted piensa que esto va a abrir la puerta hacia un ERAS que sea más dinámico, que sea más adaptado a cada situación, a cada paciente, quizás al tiempo quirúrgico? Pues no es lo mismo una cirugía laparoscópica de 1 hora y media que una cirugía laparoscópica de 6 horas. O sea, hay muchas variantes o variables que quizás podríamos intentar modificarlas dependiendo de lo que nos rodea. ¿Cree que eso es así, o que debemos mantenernos en forma rígida con el protocolo independientemente de todo?
Okay, so I think you should never follow a protocol rigidly. I have my issues with protocols, like you do by the sounds of things, because the patients are all different and the situation is all different. And you mustn't abandon your clinical knowledge, your clinical acumen, and your ability to recognize when things aren't going right. So if it was purely a question of following a protocol, then anybody could do it. It isn't. Of course you have to adapt. And the reality, you know, the things that the ERAS Society publish are not protocols, they're guidelines. Okay, and then you have to, and there are a set of principles, and I believe in the principles, but of course you have to adapt. It's just like you can't do minimally invasive surgery in every single patient. You just can't. And some patients, despite your best attempts, will develop an ileus. And so therefore, you know, you will have to put a nasogastric tube in and you will have to give them IV fluids. Of course, that's normal, I think. And I think no protocol should be too rigid. But there are various principles that you can follow, I think. Because, I mean, things like some relatively minor things, I suppose, like nasogastric tubes are quite interesting because we know that they're associated with a much higher instance of chest infection, for example. And actually, but the reality is they used to be put in routinely for a very good reason. And the reason was that patients had, for colorectal surgery, patients had a laparotomy with lots of bowel handling. They were given lots of perioperative fluid. They were given lots of opiates post-operatively. And so they all got an ileus, every single patient. And so they all vomited after surgery. And so they all got a nasogastric tube to prevent them aspirating. So you could understand why it happened. And it's only when minimally invasive surgery came along, better fluid protocols, opiate-sparing analgesia, meaning you can actually do the same operation and not get an ileus. Therefore, you don't need the nasogastric tube. So, but there will be some people who you need to do it. And there are some people who will need complex fluid management processes with renal failure and diabetes and you name it. So yes, of course, I agree with you 100%. You can't be too rigid with any protocol, but you can still have a protocol, but that you need to be able to deviate from it, of course.
Perfecto, muchas gracias. Estimo que el protocolo de alguna manera es ciertamente flexible en tanto y en cuanto nosotros hablamos de que una buena compliance, una buena adherencia, oscila entre el 70 y el 80%. Estimo que nos permite a nosotros jugar con las medidas que podemos aplicar y aquellas que no son apropiadas para cada paciente, más allá del esfuerzo que podamos poner en que las medidas se puedan cumplir, ¿no? No sé si está Tato Álvarez en línea. Tato, como dice Marcelo Viola acá en el chat, qué loco los cirujanos hablando de anestesia y analgesia. De alguna manera eso muestra, digamos, lo profundamente interrelacionado que se encuentra un abordaje mínimamente invasivo que produce menos dolor y que el manejo de ese dolor, tanto intra como postoperatorio, nos lleva a prestar muchísima atención al manejo de los fluidos, ¿no?
Sí, en realidad yo creo, y me gustaría ver qué opina Tim, que cuando uno quiere hablar de ERAS, y cuando uno quiere empezar a hacer ERAS, casi lo primero que uno debería pensar es que no hay que preocuparse mucho por la cirugía, por cuestiones de la cirugía, o por cuestiones de la anestesia. Porque uno puede hacer ERAS haciendo diferentes cosas en anestesia y diferentes cosas en cirugía. Lo que yo creo que uno no puede hacer ERAS, y ahí quiero ver si Tim está de acuerdo, es, si no tiene un verdadero equipo multidisciplinario, tener un equipo multidisciplinario no es lo mismo que juntar a 10 personas de distintas especialidades en un quirófano. Eso no es un equipo multidisciplinario. Primero, hay que tener un equipo multidisciplinario. Y segundo, el equipo multidisciplinario tiene que tener datos. Tiene que tener datos. Tiene que saber cuáles son sus resultados cuando comienza, tiene que saber cuáles son los procesos que lo están llevando a esos resultados, porque tiene que tener la posibilidad de identificar un error para poder modificar el proceso y para poder entrar en un ciclo de mejoría continua. Para mí ERAS es equipo multidisciplinario consolidado, trabajando con datos de resultados y procesos en un modelo de ciclos de mejoría continua. Si puede hacer cirugía laparoscópica, mejor, pero hay hospitales en el interior de Argentina donde no tienen torres de laparoscopía y aún pueden hacer ERAS, como lo publicó Henry Kellett en sus primeros trabajos. Él propuso esto en cirugía abierta y tuvo un tiempo de internación de 48 horas, como mencionó Tim al principio. Me parece que toda la atención la tenemos que poner en lo que es novedoso. Y lo que es novedoso es formar un equipo, tener datos, que todo el equipo se preocupe por tener datos, reunirse el equipo para mirar los datos y trabajar en ciclo de mejoría continua. No sé, Tim, si opinas lo mismo. Y comenzar lo más fácil que se pueda.
Yeah, I absolutely agree. I mean, I have to say, so when I first started being involved with this, the best thing I did was become very good friends with my anaesthetists, who were they were the same age as I was, they were very like-minded. I started doing some research and I involved them in it, and they had ownership of that research as well, and it was all in perioperative care, various fluid trials and analgesia trials. And at the end of the day, they ended up, promoting it as much as I did. So personal relationships in this are very important. And I think it probably needs to start, since I'm talking to predominantly a surgical audience, I guess. I think you do need to sort of buddy up with your friendly anaesthetists and approach this in a team fashion. And yes, you're absolutely right. You need information, you need data. Until you're up and running and you know exactly what you're doing, most people don't really understand what they're doing. And the anaesthetists often don't fully recognize the problems that the patients are having on the surgical ward afterwards. It depends how involved they are, because some anaesthetists are quite happy to be involved in the care of the patient once they've left the anaesthetic room. Other anaesthetists are completely disinterested in what happens to the patient afterwards. Equally, surgeons may not be remotely interested in what's happening to the fluid and analgesia management of the patient during the operation, and that's wrong as well. They should have an interest. And it's only by generating that mutual interest in the single outcome of the patient that you'll get good results. And I think that the personal relationships between anesthesiology, perioperative care and the surgeons is really crucial if you want to get it done correctly.
Perfecto. Gracias, Tim.
Perfecto. Muchas gracias. Tengo, en honor al tiempo que ya estamos sobre la hora, puedo transmitir una pregunta más del público. Nos pregunta Alejandro Catalani si en la analgesia espinal usan opiáceos como la morfina. Entiendo por el trabajo que ustedes habían publicado en el año 2009 que usaban diamorfina, ¿puede ser?
We actually we do actually we don't use morphine, we use diamorphine, which isn't allowed in some countries. But we use a very small dose of diamorphine together with the local anesthetic, and that prolongs the action of the spinal. So, and it may be some patients do also get a dose of opiate at the end of the operation as well. But in the post-operative care of the patient, we try and avoid the opiates altogether. So it's quite difficult to go completely opiate-free, and we do use it in the spinal.
Creo que diamorfina no está disponible en nuestro país, Tato, ¿no?
No.
con lo cual, digamos, sería un problema utilizar la morfina intratecal.
No, es más o menos lo mismo. El concepto filosófico es el que dice TIM, obtener un nivel de analgesia que permita la movilización temprana y que no esté asociado a efectos adversos, o sea, la menor cantidad posible de opioides o ninguno, pero que se permita alcanzar ese objetivo. Uno apunta a la movilización temprana, a la recuperación funcional.
Bueno, la verdad que ya estamos pasados 3 minutos del tiempo que teníamos disponible ahora. Me gustaría, antes que nada, agradecerle al doctor Tim Rockall por dedicarnos este tiempo, por una presentación muy extensa y muy precisa sobre todos los aspectos que nos interesan sobre ERAS, y agradecerle infinitamente su participación. No sé si, Fabio, tenés algunas palabras para despedirte.
Simplemente, gracias Ricardo, simplemente agradecerle al doctor Rockall por su excelente conferencia, por contribuir a difundir una manera de manejar a nuestros pacientes que seguramente va a repercutir en mejoras en la evolución posoperatoria. Y no mucho más, te agradezco mucho a vos también. Tenía alguna pregunta, pero creo que sí que estamos pasados en el tiempo, así que me parece que es oportuno dar fin acá. Te dejo cerrar a vos, Ricardo.
Bueno, muchas gracias a todos, muchas gracias doctor Rockall, Patrón, Fabio y Adrián Álvarez. Y muchas gracias a todos los espectadores que estuvieron presentes hasta el último momento. Gracias. Hasta luego.
Chao.
Bye.
Thank you very much. Bye-bye now.